Our next talk will be on cardiac CT and nuclear cardiology, strategies for minimizing dose. I'm Andrew Einstein, Victoria and Esther Aboudi Assistant Professor and Herbert Irving Assistant Professor at Columbia University Medical Center. Thanks for joining us today. These are my disclosures for this talk. Over this talk, I'd like to address why ionizing radiation has become such a concern in cardiology, radiation doses from cardiac imaging, both in terms of radiation doses from individual procedures as well as cumulative radiation doses to some cardiac patients, and then talk about dose minimizing strategies, the principles, the fundamental principles of justification and optimization, and how in particular they can be applied in cardiac CT and in nuclear cardiology. So why has ionizing radiation become such a concern in cardiology? You can see here on the screen just a few examples of advisories, reports, information statements issued by our major professional societies like the American Heart Association, the American College of Cardiology, the American Society of Nuclear Cardiology, and the Society of Cardiovascular CT, all addressing this problem of ionizing radiation in cardiology. Why is everyone worried? I think there are a few reasons. Here's an example of a study, a nuclear dual isotope procedure performed on a patient. This patient doesn't have evidence of coronary artery disease, but received in the course of this evaluation a procedure with an effective dose of 28 millisieverts, a dual isotope stress test. In computed tomography, in a worst case scenario, this can be it can be even worse. Here's an example of a patient who received a dose length product of 2,500, which would translate to an effective dose of 78 millisieverts from a single study. This patient had atypical chest pain and ventricular ectopy, and because of this ectopy, the X-ray tube on the CT scanner was left on by the scanner for an extended period of time, resulting in a high radiation dose. These may represent worst-case scenarios, but some of our patients at least receive very high radiation doses. Moreover, as we'll discuss further, some of our patients receive even higher doses in terms of their cumulative exposure. In a cohort of patients from my own institution, looking at over 1,000 patients, we found that a typical patient undergoing nuclear stress testing over nearly a 20-year period underwent a mean of 24 procedures involving ionizing radiation with high radiation doses. Moreover, the number of these procedures has increased dramatically since the 1990s. Maybe they've flattened in the past 5 years. However, the number of procedures involving relatively large doses of ionizing radiation to patients rose tremendously from the 1990s to the present. When you take high doses and multiply those by increasing volumes, what you have potentially is a public health problem. And in fact, medical radiation is the fastest growing share of the US radiation burden. In fact, cardiac imaging alone, shown in the pie chart from 2006 on the right, which reflects data from the National Council on Radiation Protection and Measurements, demonstrates that about 20% of the radiation which Americans receive nowadays derives from cardiac imaging and intervention. That's why there's this concern. So what doses do patients receive? Well, for a basis of comparison, let's look at some typical effective doses of some non-medical sources of radiation. A chest X-ray has a typical radiation effective dose of about 0.2 of a millisievert. A round-trip flight from, say, New York to San Francisco has a typical radiation dose of 0.1 of a millisievert, or 5 chest X-rays. The annual background radiation to a typical member of the American public is about 3 millisieverts, or 150 chest X-rays, and some radiation workers can receive far more. So when we hear about high doses of radiation, or it depends on how we define the term high doses, but high compared to a chest X-ray doesn't necessarily mean that it's so much in comparison to what we all receive just by virtue of background radiation. Something important to keep in mind. What doses do patients receive from cardiac studies? A typical cardiac catheterization, according to the United Nations Scientific Committee on the Effects of Atomic Radiation, is associated with an effective dose of typically 7 millisieverts. Coronary CT angiography, well, it varies a lot and it depends on the technique which we use. Let's go into that in a little bit more detail. There's a number of different approaches which we can use to perform coronary CT angiography. When we first started using multi-detector row CT scanners, we used retrospective gating and a spiral acquisition, and we didn't have tools to decrease tube current at various times during the scan. That's the highest dose procedure. We can reduce radiation dose by only keeping the X-ray tube current at its maximum during portions of the cardiac cycle when we expect that the data will be the best image quality and thus used for interpretation of that patient's scan, and decrease the X-ray tube current in other portions of the cardiac cycle. That's called ECG controlled or ECG synchronized tube current modulation. More recently, we've had introduced prospectively triggered gating, and this can be performed in a number of different manners. Even for scanners not enabling a full acquisition in a single heartbeat, we can still leave the X-ray tube on just for short periods of time in a few consecutive heartbeats and turn the X-ray tube off for the rest of the time. And then in some patients, just in a fraction of a heartbeat, we can acquire an entire image. By virtue of using different scan modes, we'll have different radiation doses. So a CT angiogram performed with spiral acquisition with no tube current modulation will have an effective dose on the order of 20 millisieverts. This will be decreased by about a third by virtue of using tube current modulations. However, if we perform an axial scan, a prospectively gated scan, that'll be associated with a markedly decreased radiation dose to the patient, reduced by, say, 80% to 4 millisieverts. Calcium scoring typically has even lower radiation doses. Cardiac SPECT, also it depends what protocol we use, depends what isotopes and the number of injections. A typical technetium-99m cestamide or tetraphosphine rest stress nuclear stress test, which constitutes the majority of all nuclear stress tests performed in the United States, is associated with an effective dose of about 10 millisieverts. A dual isotope test is associated with a much higher radiation dose, 2.5 or 3 times as much. However, if we perform a technetium-99m based low-dose stress-only nuclear stress test, we can markedly reduce radiation dose to about 3 millisieverts. And in general, PET tracers are associated with lower radiation doses than our SPECT tracers. It's important to remember that in the context of cardiac imaging, just as in the context of general radiologic imaging, there's tremendous variability. What we see here is data from the Protection 1 study, which looked at radiation dose of 64-slice CT coronary angiography at 50 sites worldwide. This was an observational study, and as you can see, the range of median doses varied nearly over an order of magnitude. So different patients will be exposed to different radiation doses, and it's important to keep that in mind. Perhaps some of this variability is necessary, but some of it certainly is not necessary. And by virtue of eliminating unnecessary variation, we can do our patients a service. Now, these are doses from single procedures. What about cumulative radiation doses to patients? We briefly alluded to this study from Columbia. A few more details now. We looked at over 1,000 patients who underwent an index myocardial perfusion imaging test in the early part of 2006. The average age of these patients was 62, and we used electronic health record systems to identify all procedures that these patients had performed on them over a 20-year procedure. And we estimated effective doses of radiation from each procedure. This was based on patient-specific information in the majority of cases where it was available. In terms of the total number of procedures, the typical patient undergoing a single nuclear stress test received 24 procedures involving ionizing radiation. Now, many of these were just low-dose chest x-rays. However, if we just looked at procedures involving at least 3 millisieverts of radiation, that still constituted a mean of 6.5 and a median of 4 procedures per patient. Mostly, these were from myocardial perfusion imaging studies, that is, other myocardial perfusion imaging studies, but also from CT scans. And in fact, the typical patient undergoing a nuclear stress test underwent 4 CT scans at our institution alone. Cumulative radiation doses, well, this dose distribution was skewed, but the mean dose to patients was 96 millisieverts, and the median was 64. Pretty high doses, and higher than the dose which a patient would get from any single study. Most of this radiation dose derived from myocardial perfusion imaging studies and from CT scans, as well as from fluoroscopically guided interventional procedures. We found gender and racial differences. Women underwent more procedures than men, which was significant even excluding mammography. But men had higher cumulative radiation doses. This is probably due to the different types of procedures performed. Women had more CAT scans and X-rays, whereas men had more fluoroscopically guided procedures performed in the cardiac cath lab. Looking at patients undergoing multiple testing, we found that nearly 40% of patients underwent multiple myocardial perfusion imaging exams. The median time between these repeat tests were 24 months, but 28% of patients had 2 scans performed within a single year. Of these patients undergoing multiple testing, their cumulative effective dose had a median of 121 millisieverts and a mean of 150 millisieverts. So what lessons do we learn from this? Myocardial perfusion imaging patients receive high lifetime doses of radiation, and that's particularly the case for patients with multiple tests. And here, as in examples in my other lecture in this session on radiologic procedures, the doses here too observed skewed distribution. Now, how can we keep radiation dose to our patients minimized? It's by employing fundamental principles of radiological protection. These are spelled out in international guidelines, and these 2 principles are referred to as justification and optimization. This is underscored by a recent FDA initiative, and the FDA states here on their website that they too are advocating the adoption of 2 principles of radiation protection: appropriate justification of the radiation procedure and optimization of the radiation dose used during each procedure. Justification is defined in these international guidelines as follows. When activities involving an increased or decreased level of radiation exposure, or even a risk of potential exposure, are being considered, the expected change in radiation detriment should be explicitly included in the decision-making process. The consequences to be considered are not confined to those associated with the radiation. They include other risks and the costs and benefits of the activity. In practice, how do we apply this principle of justification? It's really by applying and carefully using appropriate use criteria. This is a multi-societal effort from leading cardiology and radiology organizations, and there have been appropriate use criteria established in a number of different clinical contexts. You can see here examples of appropriate use criteria for cardiac radionuclide imaging and cardiac computed tomography, as well as for procedures performed in the cardiac cath lab. Here you can see from a recent publication the timeline of cardiology appropriate use criteria development. The first appropriate use criteria were introduced in 2005 for SPECT myocardial perfusion imaging, and subsequent to that, there were appropriate use criteria developed for CT and MR, for echocardiography, for stress echo, again for radionuclide imaging, again for computed tomography, again for echocardiography, and what's in the cooker for 2013 are multimodal appropriate use criteria. We're going to see shortly imaging for ischemic heart disease, imaging for heart failure, and imaging for acute chest pain in the emergency department. So this has been a huge project, and it leaves us with a lot of documents which we can use to help determine whether the tests which our patients receive are appropriate. If a test is inappropriate, then any amount of radiation is too much. How are these documents developed? Well, they all involve a lot of people. Initially, a literature review is performed and guidelines are mapped, and a writing committee develops a list of indications, assumptions, and definitions. This preliminary list goes to a review panel, and they provide feedback. In fact, I'm involved in this process right now on reviewing one of these appropriate use criteria documents. The writing committee then goes and revises these indications, and then these revised indications are presented to a review panel, typically about 20 individuals or so on the review panel. Each of these members of the review panel will review the indications and rate them in terms of their appropriateness on a 1 to 9 scale, where 1 is the least appropriate in general and 9 is the most appropriate. And then these scores are collated, and then the panelists meet in person. After this panel interaction, there's a second set of votes. After they've had the opportunity to discuss the indications in particular where there's been a lot of discrepancy. And then the finalized appropriate use criteria are written up and published. Subsequently, they can be validated. From the appropriate use criteria, we see that radiation plays, in some cases, an important part. Why? An appropriate imaging study is one where the expected incremental information combined with clinical judgment exceeds the expected negative consequences. Now, these negative consequences include the risks of the procedure, which include radiation. Here's one example in practice. Here's from the radionuclide imaging document. Risk assessment for the preoperative evaluation for non-cardiac surgery for patients without cardiac conditions. This is something which happens every day. A patient is referred for surgery, gallbladder surgery or vascular surgery, and their doctor wants to know whether they should have a stress test. In fact, many patients will go for such stress tests, but perhaps they don't need to. For example, the appropriate use criteria say that if it's low-risk surgery, and all of these terms are defined more carefully in the document, preoperative evaluation in this low-risk population is inappropriate. It's given a score of 1, and that's an inappropriate indication. For patients who are undergoing intermediate risk surgery or vascular surgery, it depends on who the patient is. If the patient has greater than or equal to 1 clinical risk factor and poor or unknown functional capacity, then it's an appropriate test. But if not, then it's an inappropriate test. There's been a couple of studies now of appropriateness, a couple of multicenter studies of appropriateness. Here's one focusing on myocardial perfusion imaging. It looked at over 6,000 patients in 6 practices across the United States. And these were, in general, large cardiology practices. Appropriateness was determined at the point of service and entered into, appropriateness was determined based on point of service data collection. This point of service data was entered into a relational database, and a computer-based logic classification was made to classify appropriateness. What did they find? About 2/3 of studies were appropriate, and the rest were inappropriate, uncertain, or unclassifiable. Looking at the most frequent inappropriate indications, number 1 was the detection of coronary artery disease in asymptomatic, low-risk patients. This constituted nearly half of inappropriate studies. In fact, in addition to this multicenter study, there's another study looking at the Mayo Clinic, which is quite a different patient population, from Dr. Gibbons and his colleagues there. They've looked also at the most common inappropriate studies for stress myocardial perfusion imaging, and they found also the asymptomatic low-risk patient here constituted half of patients who had inappropriate studies. How easy is it to improve appropriate use? Well, maybe more difficult than we might think. In the multi-center study, which we've discussed, they looked at 3 periods. 1, a baseline period, a second period after the availability of on-demand reports addressing appropriateness, and period 3 after delivery of site-specific and aggregate reports. And they found that in the 4 sites which they had data on for all of these 3 time periods, in general, there wasn't much improvement in appropriate use, except perhaps in 1 site. This was the case in the study from the Mayo Clinic as well. They performed a physician and staff educational intervention, They had standing room only medical grand rounds on their initial appropriate use publication and made this available to those who couldn't attend. They wrote a one-page summary focusing on these top 4 inappropriate indications and distributed it to all Mayo cardiologists and in a newsletter to all Mayo Clinic staff. They reviewed their findings with the medical director of the clinic handling outpatient cardiology consults, and the director met with the staff nurses who order the stress tests. And their findings and these top 4 inappropriate indications were presented at staff meetings of common orders of stress tests, that is, general internal medicine, hospitalists, executive medicine, and family medicine. What did they find? Well, after their educational intervention, in fact, the rate of appropriateness or the rate of inappropriateness, in fact, went up. This missed statistical significance, but it was from 7% to 11.7%. So it may not be so easy to improve appropriateness. One study demonstrates, however, that it's possible. This is a study from the state of Michigan, from the Advanced Cardiovascular Imaging Consortium. It's a statewide initiative involving 47 centers participating in Blue Cross Blue Shield. CT coronary angiography scans were classified into appropriate use categories using a computer algorithm, and they too looked at 3 periods: a pre-intervention period, an intervention period in which each site had the opportunity to participate in CME conferences and had site-specific interventions led by a clinical champion at each site. This entailed site-specific education, for example, grand rounds, data monitoring, that is feedback on the site's appropriate use criteria, adherence, and comparison to the network as whole. And what's most novel here is letters to referring physicians, which included imaging overuse and the possibility of losing insurance coverage entirely by Blue Cross in the absence of a definite measurable change in appropriate use. And then they had a follow-up period where they looked at quarterly comparative data, which was provided, but there were no active interventions. And if you go from the pre-intervention period to the follow-up period, after the intervention was done, the rate of appropriateness increased from about 3 out of 5 to 4 out of 5. Perhaps sticks work better than carrots, and by this perhaps threatening approach, it really increased the rate of appropriateness. Of course, it's difficult to tease apart the site-specific education from that threat of withdrawing insurance coverage from sites. But in any event, this demonstrates in the context of CT coronary angiography that a continuous quality improvement intervention can improve the appropriateness of studies performed. Our second fundamental principle is optimization. Optimization is defined as the source-related process to keep the likelihood of incurring exposures to radiation, the number of people exposed, and the magnitude of individual doses as low as reasonably achievable. That is, ALARA, as low as reasonably achievable. There are a number of optimization strategies which we can perform both in cardiac CT and in nuclear cardiology. In cardiac CT, we should employ dose reduction methods whenever possible. These include the various scan modes. As we talked about before, there are higher dose scan modes, which leave the X-ray tube on throughout the scan, and there are lower dose scan modes, which turn off the X-ray tube, except for short periods of time. By virtue of using scanners which have these low dose capabilities, these low-dose scan mode capabilities, and using these modes whenever possible will keep the radiation doses to our patients down. This was demonstrated in the Multicenter, Multinational, Multi-Vendor Protection 3 study, which was published last year in JACC Imaging. In this study, they found that image quality was identical between patients randomized to prospectively triggered scans versus those randomized to helical scans. However, the estimated radiation dose was markedly decreased in patients undergoing the prospectively triggered scans. In fact, if we perform risk estimates using BEER-7 models, the black lines on the bottom here correspond to those using the prospectively triggered scans, and the colored lines correspond to those from scans not using this dose reduction method. As we can see, reduction in radiation dose also translates to reduction in cancer risk to patients. Other optimization strategies, we should optimally select tube potential, otherwise known as tube voltage, and the current. Now, this should depend on the habitus of the patient and the clinical scenario. For example, some studies will want the best possible image quality, but for other purposes, we may be able to suffice with not quite as optimal image quality, but where good enough is sufficient. In particular, for non-obese patients in cardiac CT, 100 kVp imaging should be more than adequate, and this is reflected in SCCT guidelines. Another tool which many of us have at our disposal now is the use of iterative reconstruction to enable decreased tube current and or decreased tube potential. Here's one of the early publications from iterative reconstruction using a first-generation method from Dr. Gosling's group in the United Kingdom. In comparison to patients undergoing CT coronary angiography using filtered back projection as the reconstruction method, radiation dose was decreased by more than 50% by using iterative reconstruction. Another technique which we have at our disposal is to minimize scan length. We don't need to scan patients from head to toe, and in cardiac CT, we don't need to cover from subclavian to mid-abdomen. By virtue of minimizing the scan length, we'll reduce radiation dose to our patients. And at least for many scan modes, by virtue of lowering the heart rate using beta blockers, we can optimize radiation doses. The best practice of optimization is by virtue of combining multiple dose reduction methods. Here's one example of such a case from my own laboratory, and this patient had received a protocol which is associated with a sub-millisievert radiation dose. It's a young patient for whom we're particularly concerned about radiation, a 17-year-old girl who happens to be very thin. Her body mass index is 20. She received 80 kV scanning, a low tube current as well, had a volume single heartbeat scan, and her images were processed using iterative reconstruction, using a second-generation iterative reconstruction product. The dose length product here was 24 milligray centimeters. About 1% of that in the worst-case scenario, which we talked about early in this talk. In nuclear cardiology, we also have a number of optimization strategies which we can apply. We should know the dosimetry of competing protocols and use the lower dose protocols. In particular, technetium-99M based agents are preferable to thallium-201 when it's possible to use them in SPECT. As you can see here, the radiation dose from various protocols varies markedly, and when appropriate, using the lower dose protocols for our patients, we'll optimize radiation dose to them. It's also important to consider the necessity of each dose of radioisotope injected in a patient. In particular, we should give significant consideration to performing stress-first imaging for patients with a low pretest probability of having a stress defect, and dispensing with rest imaging entirely, that is, performing a stress-only procedure for patients in whom those stress-first images are normal. This was demonstrated in a very large patient cohort by Dr. Mamarian and Chang and colleagues. They looked at 17,000 patients with normal gated SPECT over nearly a 20-year period in their laboratory, and they found that a stress-only protocol was able to be performed in approximately half of those patients. So many of our patients who undergo rest imaging, we can probably do without that rest imaging if they're going to have a normal scan. Another consideration for nuclear cardiology, if the patients are going to have CT attenuation correction, we need to apply the principles of CT radiation optimization there. For example, minimizing the tube current. For nuclear cardiology patients, if we can get that radio tracer out of the patient's system, we can decrease radiation dose to the bladder, perhaps hydrating them after imaging where appropriate and encouraging them to micturate to get the radio tracer out of their bladder. We should try to minimize the activity of each radiopharmaceutical to that which is needed to obtain good image quality and with a high degree of confidence. For example, in smaller patients, we can consider injecting fewer millicuries. And we should consider, for all patients, where available, to use technological advances to reduce radiation dose. These include improved reconstruction algorithms, as well as solid-state cameras. Here's the study which we looked at the beginning of this talk. Here's a typical dual isotope study. The effective dose of such a study is 28 millisieverts. But this study was normal. This patient probably could have had no rest imaging and obviated the need for 2 injections. In fact, a very similar patient with similar chest pain, low pretest probability of disease, had a low-dose stress-first protocol. The stress-first images were interpreted as normal, and the effective dose, rather than 28 millisieverts for the dual isotope study, is 2.6 millisieverts here, a reduction in radiation of 90%. We can do even better. By virtue of using newer technology, we can inject less radiopharmaceutical into the patient, and here's a sub-millisievert nuclear stress test with the same net effect for the patient. Normal study or probably normal study, no subsequent imaging needed. Radiation dose reduction, 98%. But we can do even better. The best test is the inappropriate test, which is avoided. And there we can reduce radiation to the patient entirely. So optimization and justification really work in tandem to each other. The most optimized study is the inappropriate test, which is never performed. This has implications in terms not just of radiation dose, but also of cancer risk to our patients. As you can see here, lower dose procedures are associated with lower estimated cancer risk to patients. So what messages should we take away? Radiation dose to our patients and populations from cardiac imaging and intervention has grown. Data suggests that these doses may be associated with an increased risk of cancer. The appropriate response is to adhere strictly to principles of radiological protection, namely justification and optimization. And finally, a multifaceted approach to dose reduction is necessary. Thank you very much.